Hi. All right, thank you for having me. My name is Michael Wolfeld. I'm from New York. I'm a plastic surgeon. I'll get started. Disclosure, I do have a financial interest in Restoration Robotics, which is the manufacturer of the ARTIS robotic hair transplant system. So first off, just a brief overview of FUE, which is a technique for harvesting intact individual follicular units directly from a donor area using a small punch. There's a lot of, we have a lot of patients come in for consultations for a robotic FUE procedure who we just have to be upfront with them so they understand what it is and what it is not. They think FUE does not involve any surgery, that it's a non-surgical hair transplant, and that there's no incisions. The advantages of an FUE procedure is that there's no linear scar. Important for patients who really want to wear their hair short, and that's the main advantage. People that have had multiple FUT procedures and have a widened scar or a tight scalp. Patients who are athletes and who want to get back to strenuous exercise soon after a procedure. And it also can extend the size of the donor area. Just briefly, this is a patient who had a robotic FUE procedure, 600 grafts. This is what the donor area appeared like right after the procedure. This is about 6 days post-op and about 13 days post-op. So generally, we tell patients who come in for a robotic procedure that it'll be about 2 weeks until there's enough hair that grows over the scars to be able to go back to work. So the challenges in developing the robot to perform FUE was the angle of the emergent hair under the scalp, and the angle when it exits the scalp is different. And in order to develop an automated system to correct for that angle and follicular unit splay, so these two things are the main obstacles in developing the robotic system. And this is just a closer up view on a strip where you can see the divergent angles. If the punch enters the scalp at the angle where the hair is seen exiting the skin, you're going to transect the follicle. The diagram says the same things. And some of the disadvantages of a FUE or robotic FUE procedure is that grafts are more fragile and subject to trauma. There's greater patient variability compared to an FUT procedure. The procedure actually takes longer than doing an FUT strip procedure. And there may be some more greater follicular and follicular unit damage. So basically, lessons from FUE, it's patient-driven. We have a lot of patients who read about a robotic procedure, who come in, who request it, and it's basically patients see what the new technology is and they seek that out. So in the past, we used a manual system, and there's any number of manual punch systems to perform FUE. And in our office, we exclusively use the ARTIS robotic system for all our FUE procedures. And some of you may have heard of a NeoGraft as well, which is another assisted device for performing FUE. In our view, the robotic system is much better in that the NeoGraft is still a handheld manual system where you have the same risk of transection of follicles. You can harvest in one area, whereas the robot evenly, randomly distributes the punches, so it's not overly harvested in one area. There's better tissue surrounding the grafts, and there's, once again, less transection. So once again, when patients come in, they think it's non-invasive, and you have to set their expectations that it is minimally invasive. You still need anesthesia. I tell them there is scarring, just not a linear donor scar. You can wear your hair short, but you can't shave your hair, because if you shave your head, you'll see the scarring. So basically, what the robotic procedure does, and this was actually instituted in the manual system as well, the SAFE system, which was developed by Dr. Jim Harris, that there's a sharp, blunt technique. So the older systems in doing manual FUE was just a sharp punch, and currently the system involves a sharp prong that grasps the scalp surrounding the follicular unit, and a blunt punch that comes over it to perform the harvesting. And by using this sharp blunt technique, there's been a significantly increased yield of grafts. So this is a close-up view of the tip of the robotic punch system with the sharp and the blunt punches. Another view of close-up of the tip with the optical system as well. So just some logistics is the follicular units are removed directly from the donor area, which is performed one graft at a time. So graft extraction, especially any method, but also with the robotic system, is the longest step. So if you're going to do the harvesting and then make the sites and then place the sites, there's an increased time period where the grafts are out of the body, and the longer the grafts are, even whatever medium you keep it in, the longer they're out of the body, the lower chance of take. So when we started doing robotic procedures, our first step was harvesting the grafts, and then we would make the sites, and then we would place the grafts. And we realized by doing it with this, in this method, that the grafts were unnecessarily out of the body for a longer period of time than they needed to be. So currently on all our FUE cases, which are all done robotically, we make the sites first, and then we do the harvesting, and then we place the grafts, and this has reduced the time period. So once again, in a one-day robotic procedure, we do them one-day or two-day procedures depending on the size of the session. So in a one-day robotic FUE procedure, patient will come in, they receive donor and recipient anesthesia, all the recipient sites are created, the robot harvests the grafts, and then we place the grafts. And this one-day procedure will generally do about 1,800 to 2,000 grafts. Once again, the pre-making sites eliminates the delay of site creation, less time grafts are out of the body. It also increases the visibility because those sites aren't bleeding in terms of placing. And it also is good because you know the exact number of grafts that you need. If you're filling just the frontal hairline or the frontal scalp and you go in and you make 2,000 sites, well then when you go to the robot to do the extraction, you know how many grafts you're targeting. Two-day procedures, if it's over 2,000 grafts, depending on the patient, but we'll a lot of times split it up into 2 days. Scenario one, if it's about 2,000 grafts, the patient will come in the day before, we'll make all the sites. Then the following day, we'll extract and place the grafts. If it's a little bit more, about 2,500 or 2,600 grafts, we'll pre-make the sites, extract and place half the grafts on the first day, and do the remaining, extract and place the remaining grafts on the second day. So just a couple case studies. This is a 28-year-old male who was scheduled for 1,500 grafts. This is the donor area with the head shaved. This is after the extractions. Now, we did the robot originally had a 1 millimeter punch for doing FUE punches. And we did a study in our office for restoration robotics with a 0.9 millimeter punch to determine if there was any increased transection or any change in the viability or the quality of the grafts, and there was not. So currently the 0.9 millimeter punch is what's being used. So this is after about 1,500 harvests, and this is 1 week following the procedure. And this case took a total of approximately 8 hours, so it was a full day. So the robotic FUE is not necessarily a shorter case than FUT, which some patients think it is, but it's really not. This is a 2-day procedure, a patient for approximately 1,800 grafts, where the first day the recipient sites were created, and the second day the grafts were harvested and placed. This is the donor area, grafts. This is 1 week following the procedure, and this is 5 weeks following the procedure, where he still has his hair fairly short and you can't see any scars. This was a total of approximately 9 hours. Case number 3 was approximately 2,600 grafts. The first day, all the sites were created and approximately half the grafts were harvested and placed. And the second day, the remaining grafts were harvested and placed. That's the first day. This is day 2 with the additional grafts, the additional harvesting. That's day 2. And that's 1 week following the procedure. So this was approximately 16 hours over 2 days, this procedure. So just a little more detail about the robot. In order to perform the harvesting, there's a tensioner, and you can see there's sharp prongs that grasp the scalp, and there's silicone straps that are placed in little kind of divot holders on the around where the patient's head is placed, and that provides tension to the scalp because there needs to be good tension on the scalp for the robot to be able to perform the punch. And on the opposite side, there's also fiducials, which are computer readings for the robotic arm's optical system to be able to read and orient itself. So generally, we place the tensioner beginning in the posterior scalp over the occipital protuberance, and we overlap the grids, and then we move from side to side. And by overlapping the grid slightly, it eliminates vertical lines which may be visible, and centers the grid over the densest area to start. And what may be visible is if you have squared off ends where you finish your harvesting, the tensioner is a rectangular field, and ends of the harvested area may have a squared off geometric look, and that may extend the time the donor area is detectable as a hair transplant. So it's important is to feather the ends, which is just rounding the corners. We just mark with a marking pen, which is visible when the robotic arm reads that grid. You can section off areas on the computer system where the robot is not to harvest, and then you can also increase the spacing. So we generally have the spacing set at 1.7 millimeters, which is the spacing between the grafts when the robot is selecting which grafts to harvest, so you can increase the spacing so it's more spread out. That's just what the feathering of the ends look like. So this is just a technique photo once again. 2 hands are used to place the tensioner on the patient's posterior scalp. Generally, I have a nurse that's helping to apply tension to the scalp while this is being placed. I inject superficial tumescence after the tensioner is placed to add a little more rigidity and tension to the scalp. And then you can either, from the computer terminal, or there's a handheld pendant that you advance the robotic arm into position, and it reads the fiducials on the outside of the tensioner in order to orient itself to the grid. And that's, the robot then works within that grid. In the posterior scalp, in a denser area, it may be able to harvest approximately 120 grafts per that one grid. The physician is generally sitting at the computer terminal while this is occurring. You can pause the robot at any time. There's different options that can be selected if you want to increase or decrease the spacing or skip certain grafts that you don't think are appropriate. And in the background, once the grafts are harvested, once the robot performs the punches, the grafts are extracted, and then they're immediately go to one of our technicians, which is at the microscope, to evaluate each graft to evaluate its viability. So this is a closer view of the computer terminal. On the left-hand side is the zoomed view of the grafts that have been harvested. Those blue halos are grafts that have been harvested. The green is what's next to be harvested. On the upper right is the overall view of the entire grid and the orientation and the direction that the robot is going. You can see those fiducials on the outside of the grid. On the bottom right is a photograph of the last graft that was punched. So you could see if it doesn't look like it's popping out appropriately, or if it doesn't, the punch may be too shallow or too deep, and those things can be adjusted. You see the angle of the hair, which is emerging from the scalp at 29 degrees, and the computer corrects for this to enter the scalp at an increased angle, which is usually about 15 degrees, in order to follow that appropriate angle that I mentioned earlier to prevent transection. And then you see the pressure and the newtons of entering the scalp. If the pressure is really high, then there may not be enough tension on the scalp, and that can risk transection as well. So those are all things you have to keep monitoring. It also calculates the density in that area, which in this one was approximately 60 follicular units per square centimeter. So one of the main disadvantages of FUE and robotic FUE is that we tell patients, well, we have to shave the back and sides of your scalp. And a lot of patients who come to see us can't take enough time off from work to allow their hair to grow back in. and that's a big downside. And sometimes they'll choose an FUT procedure because there's less downtime, and that scar can be covered a lot easier, especially in the short term. Well, right now we do what we refer to as a long hair robotic FUE, where the patient just grows their hair quite long in the back, and we shave a band approximately a little bit wider than the width of the grid of the tensioner, so that their hair can cover over that. And we can harvest approximately 1,600 grafts with this. So this is a patient, this is the band that was shaved, and you could see after the procedure his hair covers over it and it's not visible. And like I said, we can get approximately 1,600 grafts with this band without shaving the rest of his scalp. Some of the safety features of the ARTIS system, the tensioner or grid, which is applied to the scalp, is secured with silicone straps that limit head motion during the procedure. If the patient does lift up his head or move his head while the robot is functioning, it'll automatically pause the action of the robot. The robot can be manually paused at any time using the stop button on the pendant or on the computer terminal. There's also sensors that determine the precise depth of the sharp and blunt needles used in the punching mechanism, and they have an automatic on-off switch, and if they register a pressure greater than 10 newtons, an automatic stop is triggered and the punch mechanism is retracted. They just changed the needle in that there was a physical stop, meaning that there was a lip on the needle that it would hit the tensioner so it couldn't go any deeper, but just logistically that caused some issues. So now this is a newer safety feature where it's a slimmer needle so that it can get more surface area within the grid, and it if it goes too deep or if there's any motion, it will stop automatically. So basically the ARTIS robot was approved and started to be used in 2011 for extraction from the donor area. Last year, an added capability was recipient site creation, which is being used more frequently. And in the next couple years, they're currently doing research on the robot being able to place grafts as well. At the last ARTIS meeting this past February, they have some type of cartridge that the grafts will be able to be placed in that'll be hooked into the robot, that these grafts will be able to be placed. So that's a couple years down the road. Briefly, with recipient site creation, there is the ARTIS Studio that the physician uses software to specify the incision direction, angle of incisions, the site depth, the number of incisions, and the density. And it also can detect terminal hairs and avoid terminal hairs as well. So the hairline and markings are drawn on the patient's scalp. These photos are then uploaded into the computer system, and once they're uploaded, you can specify all the options. If you want the density in the frontal scalp to be higher than the top and the back of the top of the scalp, which we generally do, you can specify that on the computer terminal. With the robotic recipient site creation, you generally don't do the frontal hairline with the robot. That's still done manually. But this can be used for more the front and the top of the scalp. You can specify hair direction. And there's a similar sort of grid for recipient site creation with the fiducials on the outside. There's two different platforms that this gets attached to the patient's scalp. At this point, it's basically just taped onto the scalp. And the patient's head is oriented with his chin down and his head elevated somewhat for the punch to be able to create the recipient sites. In reality, in our practice, we really don't use the robot very often for recipient site creation. We still generally do those by hand, but it's a capability that they're working on that's improving as well. Thank you.
Doctor, I'd like to ask you two questions. Sure.